And welcome. Thank you for joining us today for the Arnhold Institute for Global Health's Grand Rounds. We are thrilled to have you here both in person and virtually for what promises to be an engaging and informative session. I am Dr. Rose House, Director of Mount Sinai's Empath Nepal Partnership, and it is my privilege to be able to introduce the event today. As many of you know, Nepal's healthcare system faces unique challenges, especially in its rural communities. Over the years, the Nick Simons Institute has been at the forefront of addressing these challenges. The Institute has had a profound impact on strengthening of Nepal's healthcare system, particularly in these underserved areas. Their work aligns closely with Empath Nepal's partnership and our mission to provide quality healthcare services for all in Nepal. And we do that through care, education, and research. Empath Nepal's collaboration is with Dhulikhel Hospital and Kathmandu University School of Medical Sciences in Nepal, as well as the Empath Consortium of academic medical centers that's led by Mount Sinai's Arnhold Institute for Global Health. Today, we are fortunate to be joined by Dr. Archana Amatya, the Executive Director for the Nick Simons Institute. She is a visionary leader in the field of global health, and her career has been very impressive, leading maternal and child health, reproductive services, and healthcare system strengthening over the last 2 decades. Prior to her role at the Nick Simons Institute, she served as a professor at the Institute of Medicine for 20 years, and then she also has provided senior leadership roles with Save the Children. Dr. Amatya will provide us with an overview of Nick Simons Institute's work to improve healthcare in Nepal's rural areas, and will showcase the impact of these efforts that they've had in the country. Following Dr. Amatya's presentation, we'll have a Q&A session that will be led by Dr. Rachel Vreeman, our chair and director for the Arnhold Institute. So if you're joining virtually, please put your questions in the chat, and we will do as much as we can to answer those questions. And then before we begin, I just would like to thank you all for taking the time to be here with us today, whether in person or virtually. We really appreciate your interest in global health and your support of the work we're doing in Nepal. So please welcome Dr. Archana Amatya, Executive Director for Nick Simons Institute.
Good morning, everyone. Namaste, and greetings from Nepal and from the Nick Simons Institute. I can't tell you how happy I am here today morning to be with all of you who've joined virtually, as well as everybody who's here. And I would like to thank the hosts, the Arnold School of Global Health for Institute of Global Health for organizing this. And we are privileged to have Patricia, our country rep at the Nick Simons Foundation, with us today. So when we were discussing the presentation, I was not sure, besides Nick Simons Institute's work, what else could I share with the audience. So I think I will just start with something on how Nepal is working after federalism and the difference between what it was there when I graduated as an OBG and right now as I'm working as supporting the government of Nepal as a developmental partner. So I'm just going to talk very briefly about the Nepal's health system, which I'm sure everybody in this room is quite aware of. But nevertheless, I think there'll be something interesting in the slides. Then I will briefly introduce you to Nick Simons Institute and a bit detail into the programs that we are conducting from NSI. And then, as Rose said, we do have some time for Q&A at the end. So this was the latest statistics I got from the 2021 population and house census. We have a population of almost 30 million, a little more than 30 million, but nevertheless, the maternal mortality still remains very high. I remember when I came back as OBGYN in early 2000, that time the maternal mortality was 215, and the country was trying to combat this and trying every possible way to decrease it. We've worked with all different methods, new modalities, new research-based interventions. I will come that later. We're doing quite well in terms of maternal mortality and infant mortality compared to 20 years if we look back. But unfortunately, the neonatal mortality is still stagnant. I believe it's very difficult to tackle newborns. They require even more urgent care than mothers, I should say, as an obstetrician. And so we are still combating with neonatal mortality. The literacy rate, the life expectancy, and the per capita GDP still okay. And as you see Nepal on the map, right now, we have 7 provinces. You can see it's highlighted in all these 7 different colors. We have 77 districts. And we are between China and India, the big brothers, and Pakistan and Bangladesh on the east and the west. Sorry. So, as I mentioned, when I just came back as an OBGYN, that time the health system was very different. We used to work as a capital, Kathmandu, then that time there were 75 districts. And the districts the health systems in the districts were governed by the district hospitals and the district health offices. They do still exist right now, but not technically, they don't have much of a role in terms of management. And after a long, almost a decade of uncertainty, we did come into the federal democratic system in 2015. Well, as a specialist, I wouldn't know whether to say it's been for the good or for the bad, but nevertheless, we are trying to improve the health system within the new federal government's structure. It's good to know that the Constitution has emphasized the right to clean water and hygiene and equal access to health care from the beginning, even before the federal democratic system really came into place. And the Ministry of Health and Population at the center level, you can see on the right side, we have a federal government. I'm not sure if the pointer is working there. Yeah, it is, right. We have the federal government, then we have the 7 provinces, 77 districts. And within these districts, there are metropolitan municipalities, rural municipalities. So this is a huge number, especially the rural municipalities. And in this new system, the municipalities and the rural municipalities have all the right to decide what kind of health care they need within their municipalities. So if you ask me, a lot of people do ask me, after the federal system has come into Nepal, do you think the health system has improved? Yes, I would say yes. And the next question they ask me is, as a practitioner, do you see, as a practitioner and as a person working on health system strengthening, do you see that as a challenge or more of an opportunity? And I always tell everybody, in the beginning, we were working from the capital. We kind of identified what were the needs all over the country. 80% were correct, probably 20 were not. But right now, after federalism, now these municipalities and the rural municipalities, they know what they need. Of course, I agree that they have technical deficiencies. They don't have enough technical resources to handle it. But I think that's just a stepping stone for them. And they are doing a good job, I should say. So at the federal level, we still have the Ministry of Health and Population, which has the central hospitals. There's some 13 or 15 central hospitals. There are councils, professional bodies. And then there is the Department of Drug Administration, the Department of Health Services, and the Department of Alternative Medicine, Ayurveda. At the province, some of the provinces have named their ministries as the Ministry of Health. Some of them have named them the Ministry of Social Development, which also looks after education. And then the provinces have provincial hospitals, And at the same time, the good thing about federalism right now, I should say, is they have their own provincial reference laboratory. They have their provincial health centers. And I think this is a boon for federalism, because now each province would know what kind of trainings they would really need to focus on and what kind of cadre they require. They have their provincial logistic management center, which I say is wonderful, because now each province can know what kind of supplies they require, not necessarily everything being what the central government has sent them. And then there's the provincial health directorate, which looks after most of the public health programs. At the local level, as I was saying, all those 460 they have their local hospitals, and then they have these primary healthcare centers, the health post, health urban clinics, basic healthcare centers, and community health units. So although the lowest box is kind of confusing, the main thing is that, depending on the population and the distance, they would provide just daycare, immunization, family planning, things like that. And as you go up, they go on to having primary healthcare centers with 15 beds or above, and the local hospitals as well. Yeah, just a snapshot of how we are in terms of the maternal mortality ratio by province. The Kathmandu is somewhere here. This is Bagmati, where the capital is. Karnali is one of the most difficult provinces in terms of geography. And it's one of the most isolated places as well. So you can see that Karnali and Lumbini is towards India, geographically challenging, but in those two areas, the maternal mortality is high. And I was involved in a census we did some time back, a couple of years back. We went through all the records of maternal mortality to find out why these two provinces had the highest number of maternal mortality. And interestingly, it was seen that referral was one of the improper referral, and not being able to handle referral cases immediately was one of the biggest reasons why maternal mortality was high. In Karnali, I think, it's difficult. At some places, besides the helicopter, there's nothing else there are no roads at all in 2 or 3 districts. In Lumbini, most of the referrals came very late because they were referred from Lumbini, maybe from Sudur Pashchim to Lumbini. So when they came, they were in a kind of irreversible stage. So that was one of the reasons why maternal mortality was so high in these 2 districts, in these 2 provinces. And interestingly, when I came back, we did say that, when I took classes, I always said that hypertensive disorders of pregnancy, obstetric hemorrhage was the most common cause. And I'm still saying this after 20 years. So, we've done so much to combat this, but in spite of that, we still have, unfortunately, hypertensive disorders and obstetric hemorrhage as the leading cause of death for mothers. But these days, we do see that we have other pregnancy-related sepsis, other obstetric complications increasing, and non-obstetrical complications as well. So that's about how Nepal is right now. And I just go into Nick Simons Institute. I feel very proud when I show this picture. We have a lovely office, and I was telling David and Rachel that next time you have to come and visit our office. You'll love it for sure. And we don't have a very big team in Kathmandu. This is the team. We are about 35, 38 right now. But all over the country, as I go forward, I'll tell you where we are supporting. We have about 300 doctors, nurses, technicians all over the country in the hospitals that we are working. And here we have Nick. I'm sure you must have heard about him and about his family, Jim and Marilyn, who have such a big heart and who love Nepal so much, and they've done so much for Nepal. And it's because of them I'm able to stand here and talk so proudly about Nick Simons Institute and the work we have been doing. Unfortunately, we lost Jim last year. It's exactly a month. We lost him on the 10th of May last year. But Marilyn has always been a very strong pillar of support for the Nick Simons Institute. And we have a very distinguished group of board members with us. And these are all our board members We have Dr. Thapa, who's been the ambassador to the United States. He's been the finance minister and a pillar of support to the Nick Simons Institute. And these are the rest of the board members. So this was, I think, Jim's last visit in 2023, yes, 2023, with the NSI family. And yeah, I forgot to say something important. Yes, right. Nick was in Nepal in the 2000s, and he loved Nepal a lot, and he always wanted to do something for Nepal. Unfortunately, we lost Nick in a drowning accident, and then Jim and Marilyn wanted to keep his dream of serving Nepal alive. So that's where the Nick Simons Institute was established in 2006, and from the beginning, we have been working on innovative solutions to innovate solutions rural healthcare through training, hospital support, and also not only that, but to advocate for their scale up within the government of Nepal. We work only with the government of Nepal. The government of Nepal, Ministry of Health and Population is our sole partner. So, they require support in terms of training, in terms of human resources, logistics. So that's how, we are working. And along with the central government, also with the provincial government, with the 7 provinces. Our vision has been people in rural Nepal receiving quality healthcare services within their own community. And that has been our mission and vision since the beginning. We started in 2000 and we established Nick Simons Institute in 2006. And from there, we've come a long way. We are here right now with the Rural Hospital Strengthening Project, although the names are different for the projects, which are every 5 years. The mission and vision on supporting rural healthcare, strengthening rural healthcare health system has been the same. Our focus areas is on training. I'll go into this in detail on curative service support program, the hospital strengthening program, and our monitoring and evaluation program. When Nick Simons Institute was established, that time the government of Nepal, this is our 19th year. Next year we'll be 20 years old. The government of Nepal had mentioned that there are 3 areas where support is very required that time when we started. One was we don't have enough human resources at hospitals. So that's where the curative service support programs addresses this. Another area where they were deficient was on training human resources. They didn't have enough people who were trained to give different services. And of course, quality was an issue and logistics in terms of equipment. So I know this is quite a condensed slide, but I just like to share that, you can see H, the blue one. We are all over the country. Right now in this project cycle, we are with 40 hospitals all over the country, almost all over the country. We are supporting the government of Nepal, the training center, in 21 training sites. That is, you can see T. We don't give training directly ourselves, but we liaise with the government. Whichever training is required for them, we support them. And we have right now the provincial biomedical unit. This was 6, but after I flew this trip, we inaugurated the 7th biomedical unit. So now we have 7 biomedical units all over the country. So, if you look at where NSI is not there, it would be hard to find. Till now, we have 6, as I mentioned, 77 districts, but we've been working in 61 districts plus since we started. I'll just briefly run through the training program. What do we do in the training program? We don't just give training. We also, along with the training conduction, we also try to support them to develop the training sites. So, the government wants to develop a training site in one particular province, then that is a long process in terms of getting the training site equipped with all the training material, getting the accreditation from the National Health Training Center, getting enough people trainers. So we do a lot of work on that. I will tell you what we mean by biomedical support. This is the provincial biomedical workshop and the hospital biomedical workshop. I'll come to that in a while. We are also working with the government to develop curricula and revise. Just recently, we developed 2 new curricula for the government: the hemodialysis for nurses and biomedical equipment for the revised course for technicians. So as the years come, what is required, the government would tell us what is their need, and we would work with them and support them accordingly. And it's high time we are now going to revise the skilled birth attendant curricula as well, because there's been a lot of changes and a lot of new evidence-based practices. We also work in building the capacity of these training sites, the trainers, the leadership team over there. And besides this, as required, we do support the government on this. So sorry for this slide. I think it got clumped somehow, but nevertheless, our training programs are divided into the long duration trainings and the short duration. The long which is more than 30 days. For example, the diploma in the biomedical equipment engineering. This is something which is only Nick Simons Institute has started. And I'm proud to say that it was one of our babies and something very, very close to Jim Simons' heart. Because we realized that, as we were working at hospitals, you give them equipment, you give them doctors. But if something happens, then because of a small equipment issue, they're not able to give services. If you ask me whether I can change a plug point, I cannot. I have never done it. And, so that's where this idea of the biomedical equipment engineering management came in. It's a 1.5-year course done by the National Health Training Center. Until date, we have produced almost 200 plus biomedical equipment technicians. The anesthesia assistant course is another very noble and important course for the country. When I came, we had just some 60 anesthetists in the country. Right now, we have 600. But nevertheless, more than 2/3 are working in the urban area. 1/3 is abroad. So in all these hospitals, which I just showed you, we don't have an anesthetist at all. And we will not have it for another 10 years. That is for sure. So that time, what is the alternative? So an anesthesia assistant course was developed. So that's a 1-year course. They would work under an anesthetist, and they have certain criteria. They can give spinal anesthesia, they can support for general anesthesia, but they are supervised by an anesthetist or a general practitioner. They're not allowed to work alone. But I think this has been a great help for the country, because because if there's just a single anesthetist or a general practitioner with a hospital which has about, let's say, 50 C-sections a month, I think the anesthesia assistant is a huge support to the general practitioner. So this has been a very important course. I was just talking to our the ministry on the future of this. How long are we going to continue working with this? I think for quite some time we will still support. We'll be doing a lot of work working with the government for the skilled birth attendant. For those who don't know what a skilled birth attendant is, it's because we don't have enough OBGYNs all over the country. We train the nurses, the staff nurses, for 28 core components, so they can manage immediate obstetric complications before you can refer to an obstetrician, or an obstetrician can come. I think this has really contributed to decreasing the maternal mortality. And an advanced SBA is a medical officer, a doctor, who is trained for 72 days to be able to conduct cesarean sections. Because at some places, we might not have obstetricians. So, it's not always possible to refer all the cases who require C-section. And as we are aware, 5 to 15% of complications occur all the time. And another very important one is the mid-level practicum, because, as we are talking, you must have realized we're talking about doctors and nurses, but we have not really, mentioned about the health assistants and the auxiliary health workers. These are the two cadres who are the backbones of the primary healthcare system in Nepal. So we have a mid-level practicum, which is about 90 days, and then these cadres, they are taught about basic life support, emergency obstetric care, primary emergency care, so they can manage emergency immediately. And another very important one is the operation theater technique management. So the nurses are well versed on how to assist the doctors at the OT. I think all of these, if we look at it, I think all of these trainings lead to quality of care and efficiency as well. And we're also working with the short duration, like the primary emergency care, essential critical care, and the biomedical, medical lab and technicians as well. So, as I was saying, Nick Simons Institute with the Ministry of Health, we are able to identify some unique health cadres. Anesthesia assistant, as I just mentioned, that's a task shifting and a task sharing, so that, in less specialized hospitals where we do not have an anesthesiologist, probably just a general practitioner, these anesthesia assistants are supporting them. The biomedical technicians, you could see, this is a common picture you would see in many hospitals in Nepal and probably other parts of the world as well. Small things goes wrong, we don't know who's going to fix it, and we end up buying new things. So this is the biomedical technician is the one who's undergone 18 months of training. They can fix certain things, and I think in the country they're doing a wonderful job. And we have tried to establish a small biomedical unit in the hospitals that we are working. So small things get fixed there, something like if a suction machine is not working. Things which cannot be fixed there are brought to the provincial biomedical unit. And if it's not fixed there, then only it goes to the vendor or it comes to the central biomedical workshop. So we're trying to reduce the time and also the efficiency for mending the equipments on time. As I said, the training site development, we are trying to train people. We are trying to establish training sites so provinces are independent and they don't have to rely on the center government only for trainings. And this is what I love this picture, because this is what a provincial and a biomedical unit looks like. So they have all these equipments, they have some repair equipment inside, so they can repair all these small things which needs repair at hospitals. And these are a group of very wonderful, young, energetic people. Recently, as the government of Nepal in 2015 were a signatory to support midwifery care in the country. The Nick Simons Institute with the government of Nepal, we've been working on developing midwife and SP-led birthing units. So we just started this. Right now we are working in 2 hospitals. This is in Bharatpur Hospital, one of the busiest hospitals in Bagmati. And right now we have it in Thapatali, as in the Paropakar Hospital, Women's Hospital in Kathmandu. So, it was difficult to bring midwifery care in the country because we were relying so much on nurses only. But, if you look at it, I think with global evidence, we have seen that, obstetricians cannot take care of all the emergencies all the time. We need somebody between a staff nurse and OBGYN, and midwives were the best cater for this. And we do believe that, gradually the country will have more midwives. They will be taking care of obstetrics care and supporting to decrease the maternal mortality. So till date, I think from 2006, 2007, till date, we've trained about almost 8,000 workers, about 800 to 1,000 annually. We've developed more than 200 anesthesia assistants and biomedical equipment technicians. And now we have 7 biomedical units all over the country. So this was last year. Last year we did a fairly good job. We were able to train 980 people on all the different trainings. And when we are training, these red ones are the training sites. So you would see in this province, there's just 1 training site. In Bagmati, you would see 5. That all depends on the government's need and their request for training site development. Curative service support program has been one very important component of the Nick Simons Institute's work. We believe that primary hospitals should be able to provide emergency surgical care. So when I say emergency surgical care, it's not only obstetric care, but mild at least bellwether, which is, you manage a closed reduction or fracture, you can do our emergency laparotomy, and you can do cesarean section. If these three things are ensured at a primary hospital, I think we would do a very good job in terms of surgical service strengthening in the country. So this is okay. Yeah, right. So these are the red dots are showing where Nick Simons Institute has been supporting. So we've been all 7 provinces, out of 77 districts, 48, we've been there in 48 districts, 61 hospitals. And gradually what our modality is that we work in a hospital for a certain duration of time till they are strong enough to become independent, at least to give services. And once they are, then we step out and go to another hospital. So, we're doing quite a good job, and all over the country, supporting a lot of hospitals to start surgical services. So when we are talking about the curative service, we're not only talking about the human resources. Human resources is an important component, no doubt. We are, liaising with the government. So, the government would put a number of doctors, a number of nurses, which is not sufficient. So Nick Simons Institute is adding more, especially around the general practitioner, which I will show. So another very important component, what makes doctors or nurses or other cadres stay in rural settings. So one thing which was important was their living support, because they didn't have good living quarters. They didn't have basic things, they were not staying there. So what we are doing is we are supporting for living support as well. And they required the essential equipment to give services. So the government has given enough equipment, but nevertheless, it was still required. And another very important component was their capacity required to be enhanced over the years. Just one time of a degree was not important. So how we work at the hospitals is we have a general practitioner who leads the team. And the general practitioners in Nepal are a bit different from the general practitioners in the rest of the world. Our general practitioners, they have a 3-year training program following their basic medical degree, and they spend a lot of time working in obstetrics and gynecological department, in the pediatrics and anesthesia. So when they come out, they are able to give spinal anesthesia, manage critical care to a certain extent, and do cesarean sections and other minor gynecological surgeries as well. The whole idea was that this cadre would go to a primary healthcare center and give at least emergency surgical services. And over the years, this program has been taken as a very important program for Nepal. And I see this as, I would not be able to envision that the very rural hospitals would have an obstetrician or anesthesiologist for a very long time. And the government has also realized this. So the general practitioner program is something which the government gives a lot of emphasis. And we are proud that, we are supporting to the government on this important endeavor. So along with the general practitioner, we have kept an anesthesia assistant, as I just mentioned, a nurse who is trained in operation theater technique and SBA, a medical officer who can do a cesarean section, and a biomedical technician. We believe that if we have a cadre of these 5 people, at least emergency management will happen at a primary level hospital with the minimal resources. And we were able to produce this in one of our recent journals. And kindly, I would request you to go to this link and read the article. I think it's come out really well, and the government has also endorsed it. And a lot of people have also recognized this model. I was in Indonesia a couple of months back, where we were sharing different modalities of working in primary health care. And that was in Jakarta, where the Asia-Oceania region people were there. And they were really surprised on how Nepal has promoted general practitioners and developed this model to manage emergency care, because surgical care is always a big challenge. It's very expensive, the outcome doesn't come immediately, and it's a long duration outcome impact, So many partners are not very interested in supporting, in promoting curative care. And I hope the scenario does change gradually. Yeah. And we are also giving equipment for the hospitals, so they can give all the required services. Interestingly, after COVID, the hospitals had enough equipment. Plenty, in fact. So these days, our involvement in supporting essential equipment is not so heavy as we did in the past. And And as I was saying, if I was a doctor in a very remote part of Nepal, would I stay there? I don't know. So what we've realized is, at least, not just doctors, nurses, everyone, that they require basic services and basic amenities. So what we are doing is we are renovating rooms over there. We are furnishing. We are renting places. At one time, we were also constructing. This was one in Kalikot, which is in one of the remote parts of Karnali. We built, I think, 4 of these kind of dormitories for the doctors and other health cadres. But right now, we are just focusing on renting and furnishing. But I think it has helped them a lot, especially in places where you send a health cadre who doesn't know where to stay once he or she is really motivated to go and work, in spite of being motivated. So I think this has been a good initiation. We're also giving them internet services, and as I said, to build their capacity further, we are sending them for trainings, for continued medical education as well. So this was last year. We supported almost 300 human resources, the anesthesia assistant, the general practitioners, the medical officers, the staff nurses all over the country. This year, we have a target of 300 human resources to be supported, along with the support of the government of Nepal. And, if you look at the program impact, I'm not going to go into the numbers because the service utilization has really gone up. Yes. I really appreciate the government of Nepal's support to enhance primary health care in the country and curative health care as well. And that's why it has been easy for Nick Simons Institute to show that how important, strengthening primary hospitals for curative health services and medical emergencies is important. Well, if I step back and see, all these years of supporting hospitals, what did we achieve? One thing is definitely we've been able to keep doctors in rural and remote hospitals. And that is a challenge for the government of Nepal because of various reasons. The hospital service utilization has gone up. And, I'm proud to say that surgical facilities at primary hospitals has really gone up for emergency cases, because it would be kind of, unfair to say that, you cannot even do a C-section at a 15 to 25 bedded hospital. So at least right now that has happened. We've been able to continue medical education for hospital staff and biomedical equipment labs in all the 24 hospitals. And just to show you that in 2008, when I came back as an obstetrician, a little after that, only 13 of the 77 district hospitals were doing cesarean sections. For over these years, with our support, with other partners, with government, hand in hand, almost 76 hospitals are doing cesarean section. And I think that's a big, achievement for the government of Nepal. And as I was saying, a lot of partners, a lot of NGOs, they are interested in more on the preventive sector because you get the results and the indicators are easy. But strengthening a hospital to provide clinical services has been something which, we do a lot of advocacy. Yeah, right. And working over these years on hospital curative support, we realize how important quality is. Because at one time we were addressing numbers, human resources, we are talking about equipments, but then where is quality in all this? So right now we are working with the government to develop hospitals. It's called the Hospital Strengthening Program, although we've developed a tool with them, which is called a minimum service standard tool. So we have minimum service standard too for all the levels of hospitals, from 15 beds till a very super specialized, which means that, if you want to start, let's say, general surgery in a 50-bedded hospital, if those standards meet, you are able to give services. Otherwise, you have to make sure that you do it. And the best thing about this is that the government has owned this. It is their flagship program. They do it biannually. They have scores. Then they make action plans, and whatever is they lack in the scoring, they would improvise for the next annual MSS event. So I think this has given them an opportunity to look where they really need to look in depth, because sometimes you look from a very superficial aspect, probably about only the human resources you count the equipment, but in terms of services, minimum service standards has really set a very good platform for working on quality, and we are still working a lot on this with the government. So if I look at Nick Simons Institute at a glance, I would say that the curative services, especially cesarean sections, but we are still working on making sure that the general practitioners can manage medical emergencies, and also general surgeries to a certain extent. We are working very closely with the Ministry of Health and Population, and a friend of mine was telling me it's like moving an elephant. It's not easy. Working with a changing government is very difficult, but nevertheless, we've been doing a good job, I think. We've done very small things, I think, if you think of the input, but the impact has been huge. And I feel very proud when I talk about anesthesia assistant, biomedical equipment technicians, because even when I travel to see all the hospitals that we are working in and the other hospitals as well, the wonderful job that this cadre has done is something which I cannot express. And I always give all this credit to my senior people who were in the Nick Simons Institute and the government, who sat together and thought how important this is for the country. And the best part is we've never worked in silos. Everything we do, it's been the government system. So now the government has sanctioned posts for the anesthesia assistants and the biomedical equipment technicians. So it's their program. We're just there to support them. And the health system strengthening model has never been a vertical model. It's always been very horizontal. And we're doing a lot of work on research and advocacy, because we believe that all the work that we have been doing with the government has to be brought up and shared ahead. So we have a very strong results framework, which we are linked to our 16th plan and the Nepal health sector strategy goal. So all of our the hospital support program, the current one, the goals are linked with this. And we do take out 2 to 3 policy briefs every year in terms of our advocacy program, the work we are doing, how important it is, and what are the results that we've come out from that. We have a Nepali advocacy newsletter, which is called Awaj, that means sound, and we interview different important stakeholders all over the country, and so they can share their views on it. We do a lot of work on publishing our work. We have the Nick Simons Foundation team with us to support this, and this has been great. All these publications to be able to show how the country is strengthening its health portfolio in different ways. We have this is our website, www.nsi.edu.np. We have a very active Twitter and a Facebook page where we post all our recent happenings. And along with this, as we were working in developing and strengthening surgical care, we realized that the government requires a very strong national surgical, obstetric, and anesthesia plan. In South Asia, I know that Pakistan has developed this, and then Nepal also was a signatory to develop its own NSOP, because without an NSOP, I don't think it would be too over. I mean, I wouldn't know the exact word, but I can say how you would determine what kind of surgery should be done in which hospital. So with the Nick Simons Institute's support, the government of Ministry of Health are now working in developing the NSOP for the country. And I think this is going to be a huge milestone. This is going to be a living document. It's not going to be a standstill, okay, so many surgeries in this hospital, but nevertheless something which is guiding. And we are working with the PGSCC and the Global Surgical Foundation to develop this. We do hope by the end of this year we will have it ready. And the best part is yet to come. We conduct a rural health workers conference every year. And you would see this huge, there are some 100 people, and we want the very rural health workers to come, the nurses, the medical officers, the health assistants who never get an opportunity to come out of their workplace ever. So we bring them together. We share. They get to hear all the high-level officials of the government talk about different health agenda. They get to network with each other. They share their posters. They're able to speak about their experiences. And we have 5 people who are chosen as the Nick Simons Award. This was last year where Marilyn was there, and this is the health minister. This young gentleman, he was a health assistant from a place in Bagmati province, but a remote area, who's done a wonderful job. So this is a kind of motivation for them. And I always feel so overwhelmed when I meet all these people, because I think I'm doing a good job, but these people are doing much more than what we do in Kathmandu. And we were honored with the WHO Sasakawa Health Prize in 2023. I believe the Sasakawa Health Prize is given only once to somebody in Thailand and somebody in Sri Lanka. So Nepal was, it was a true honor for us to be able to receive. I got to meet Dr. Tedros during that time as well. And I can't go without saying a very big thank you to the Ministry of Health and Population in Nepal, the Nick Simons Foundation, Patty, Dedre, and my whole team, and everybody at the Nick Simons Institute. So I think that's it. Thank you very much. Thank you. Right. Yes. I hope I was not too boring.
Let me just say on behalf of everyone here, thank you so much for sharing, Dr. Amatya. We have just a bit of time for a few questions. For those who don't know me, especially those joining online, my name is Dr. Rachel Vreeman. I'm the director of the Arnhold Institute for Global Health here at Mount Sinai and the chair of our department. And I was just thinking, we are so close in many ways. Our Department of Global Health at Mount Sinai is actually called the Department of Global Health and Health System Design. And our focus within global health work and where our faculty and where we've chosen to focus in our partnerships is also around health system strengthening. And it's so exciting to hear the depth with which the Nick Simons Institute in Nepal has embraced and strengthened health system strengthening. And I think from what you've described, we can really see all the different levels of how you've moved that forward. We often, I think too often, people might think that if you're doing health system strengthening, oh, maybe this is building hospitals or equipment or people. And of course, those things are there. But just as you've described, there are so many layers from the training to thinking about the biomedical engineering to thinking about how you retain healthcare workers by supporting them with reasonable places to live and the resources they need, and even those kinds of opportunities to gather together and network and be recognized. So it's just really, really terrific to hear those examples from you. I know we don't have a lot of time for questions, but I'm delighted to have a little bit of time to ask you. Maybe I'll start and then we can see if there are some other questions. I did want to ask, so really seeing this terrific example of how the Nick Simons Institute has moved rural health system strengthening forward over these years in Nepal. I wondered if you could pull out for us a few of what you think of as the best practices for following in this kind of work? You've given us a great example of what you've been able to accomplish. And when you think about global health partners, what would be the best practices that out of the work you would recommend in that way?
What I think one important way that we can work in partnership in terms of best practices is on finding out how we can do better at these hospitals in terms of giving services, not just curative services. Right now, we have so many other, like, for example, an NCDs or probably mental health, things like that, where, one partner would probably not be able to do everything. So I think that's a very important dimension that we need to think about. And we are thinking in that manner as well, because our focus right now is on curative health, and we believe that the government still requires a lot of support, but we are looking for ways to work in non-communicable diseases, in mental health to a certain extent as well. So I think that's important. And another important thing is, I think, developing all these cadres, it's going to be an ongoing thing, it won't just end when it's 250 or something. Sure. So we are also working on ways, how can we make the government take the ownership of this, of all of it independently? Would there be somebody else supporting? How would we support? So I think those are two important things which come to my mind right now.
Sure. So I hear you talking about the needs for both collaboration and thinking beyond specific curative measures as critical parts. And then it actually fits. I was even thinking of asking you a bit about how you consider sustainability in the models of what you're doing. And it sounds like even from the beginning,
Yes.
by partnering with the government and the
Right.
ministry and that, and really trying to build in models for
Absolutely.
sustainability. And again, we've talked about this a little bit earlier, but in our work in Nepal, we've chosen to we focus in a bit more of a specific area with a specific academic medical center with the Kathmandu University School of Medical Sciences, the Dhulekal Hospital and their systems. But in that too, thinking about how this creates a sustainable system of growing new learners and healthcare workers, of having the government support in that and considering what that community health model looks like. That's terrific. Are there any, maybe we have time for one or two more questions. If you wouldn't mind using the microphone, Dr. Morrow, that would be terrific. You were the first I saw, so.
First, just thank you so much for that excellent talk. Really very impressive work over almost 25 years, I think you said, or 20 years, I think you said. This is 19. And I feel like I have definitely seen firsthand some of the impressive impact that the model of supporting and training rural health workers has had, especially in rural areas in Nepal. One question I had was, I feel like one kind of important piece of the functioning or quality functioning of a rural hospital is around communication and record keeping. And I was curious about NSI's work in electronic health records, if that's been something that you've worked on, or even record keeping non-electronic, kind of the idea of appropriate handoffs and communication and record keeping for individuals who are maybe revisiting a primary health center over time. And then the second question I had was around, you mentioned referrals, and referrals being a big piece of kind of the key to why mortalities had happened at such a high rate in those two provinces towards the western side of Nepal. And I was curious about referrals from hospitals that you've strengthened to even higher level facilities. And I know, Nepal has a program of helicopter delivery when a maternal mortality is anticipated, but I was just curious about other forms of referral pathways from a primary health center outwards.
Thank you. I didn't get your name.
Oh, sorry. Sheila.
Sheila. Okay, thank you, Sheila. Well, I'll take the second question first, because that's one of my favorite topics, and I always love talking about and telling people how important referral is. Yes, you're right. The government of Nepal, as themselves have now developed a very strong referral mechanism. They have made, for example, I'll just give you a small example, which is very impressive. From a primary level hospitals, they have a list of ambulance drivers. They have a list of people who are willing to take these people down. And also they have the contact numbers of all the let's say, for example, labor room, the contact person of the maternity ward in charge. So when a referral takes place, then the system is in place these days compared to one time where it was very difficult. So, you need a referral, you call directly the ambulance driver, and then you call the referral hospital so that the referral mechanism happens intact. But having said this, because of the geographical terrain, although WHO says that 2 hours of radius is enough for one referral, it doesn't always work in hilly and mountainous regions. And that is still a challenge, but the government is still working on it. And compared to what it was 10 years back, things are much, much better now. Regarding electronic health recording, that's one very important thing, but which is kind of still undecisive for the government because of its intensity and a lot of privacy issues as well. The hospitals where we are working right now, we are supporting in 10 hospitals to manage the electronic health recording. So, and there are other partners, because I think for digital health, everybody's interested for various reasons. So I was told that almost 80 or 90 hospitals are using 10 or 20 different software. But recently, just before I came, we had a meeting with the minister, and he's now agreed that we will have one central data repository in the ministry. And all these different hospitals who are using electronic health recording, their data would come. So it will give the leadership an idea of what exactly is required as they plan for the next year. But nevertheless, although my experience of working digital health for the last some years, it's a challenge. It is a challenge. I think that's everywhere.
Sure, absolutely. Well, I'm afraid we're actually at the end of the hour, so we're going to have to draw things to a close. Thank you so much, Dr. Amatya, for your insights. The work that you are doing, your dedication, your commitment to improving health systems really shines through as you talk about this. And thank you for sharing those lessons and that with us today. Thank you to everyone who is able to join us, both those who are here in person in the room, as well as those who are joining us virtually. We really appreciate this chance to think more about health systems in Nepal and again, to think about what the work of the Nick Simons Institute is there. If people, there are some refreshments for those who are here in person that you are welcome to enjoy, and we have a little bit of time together in person that way as well. Please also feel free to reach out to us at the Arnhold Institute for Global Health, whether you want to be put in touch with the Nick Simons Institute or to have further questions related to Mount Sinai's work in Nepal as well. We're happy to make connections for anyone who might be joining us today as well. So again, thank you. Thank you so much.